कहा कि प्लीज मुझे निकल जाने दो 6:15 6:20 को। मैंने उनको कहा 6:30 के पहले मैं निकल आऊंगी, डोंट वरी। तो रुके हैं वो ऑफिस वाले जो हैं
जी।
आज सुबह से जरा घूम ही रही थी, धुलिया गई थी कलेक्टर साहब को मिलने, डीएचओ सिविल सर्जन को उन्होंने वहीं बुला लिया था।
ओके।
सुबह से कुछ कुछ चल ही रहा है।
हाँ, तो मैम जहाँ जाए।
नहीं, अच्छा, मुझे आज बहुत अच्छा लगा उनके साथ बैठ के बात की ना, क्या करना चाहते हैं। फिर मैं जो एजेंडा ले गई थी उसके बियॉन्ड चले गए, तो आई वॉज वेरी हैप्पी।
यस।
एकदम क्वालिटी टाइम दिया, 1.5 घंटा
पीयूष
वगैरह,
जी, पीयूष जी,
वेरी क्वालिटी
Yes,
टाइम
ma'am.
दिया, तो मुझे अच्छा लगा।
live streaming has started, so
Yeah.
I think you can start the session, please.
Sure, ma'am. Sure.
Our
Just
guest of,
let me share the screen once.
yeah, guest of honor is already here, so you can start.
Namaskara, good evening, a very warm welcome to the Happy Learning Masterclass webinar series, edition 197th, theme mixed bag, today on 25th June, sharp at 6 p.m. A very warm welcome. This is Piyush from Corona Remedies. Welcome you all to this platform, to this webinar, or to all those who have joined us through our faculty link and all the people, those who have joined us through our live session. Proceeding further, I'd like to introduce to our convener, Dr. Asha Jain, ma'am. One thing which I'd like to say is that the lady needs no introduction, but yeah, I'd like to mention some of major achievement which she has. She's the current offices, like she's director, SMSA Hospital Raipur. She's she's medical director, CPRS NGO, elected members, Chhattisgarh Medical Council, zonal chair, Foxy Food and Drugs, MSc Committee West Zone, Chairman, Mission Pink Health, IMA Raipur, Executive Member, ISCCP, Chhattisgarh SRN, Chhattisgarh SFM. She is really a great personality, and
So I think that's enough. These
I'd
are
like
all
to
teachers,
hand over the
boss.
session to her. Ma'am, please.
So you may stop sharing for a second and I will welcome everyone and we can start again. So namaskar, namaskar all the dignitaries to this platform of happy learning. This, as you have seen, this is 197 and it has a lot to say for the consistency and dependability of Dr. MC Patel sir, whose brainchild is this happy learning masterclass. Sir, I request you to give the welcome address before we take the program further.
Only 1 minute.
We can hear you, sir. We can hear
Oh,
you.
yes. Oh, yes. Oh, yes. So, thank you, Dr. Asha. It gives me immense pleasure to welcome you all on 197th episode of Happy Learning Masterclass web series. And today's joining society, Amravati, Gondia, Nanded, Yawatmal, and Sewagram, Wardha. I welcome Dr. Shakuntala Chhabra, madam. She has kindly consented to be chief guest to bless us. Of course, she is always with us in any of our academic activity. In spite of her busy schedule, she is working in remote places, and there also she had promised me to join this webinar to bless me for this webinar. Thank you, madam, for sparing time for me and for this webinar.
Thank you.
You are always source of inspiration for so many of us. Mere presence of yours is enough to inspire us in this type of academic activity. I also welcome Dr. Pushpa Jhungare, madam, from Amravati. She has kindly consented to be guest of honor to bless the webinar. Of course, she is also with us in any of our academic activity. Welcome, madam. I also welcome learned speaker, Dr.Poonam Verma, madam, from Sewagram, Wardha. She is going to discuss very important point of eclampsia as far as this management part is concerned. And to chair that very important session, I welcome three learned chairperson, Dr. Suyoga Panat from Amravati, Dr. Girish Mane from Yawatmal, and Dr.Anil Sakhre from Nanded. I also welcome one more speaker, Dr. Rashmi Kahar President of Amravati ObyGyn Society, and she is going to discuss about physiology and its screening part is concerned about hypertensive disorders of pregnancy and preeclampsia. And to chair that important session, I welcome three learned chairpersons, Dr. Megha Ratnaparkhi from Gondia, Dr. Supriya Pandit from Nanded, and Dr. Shefali Jain from Gondia. And as far as panel is concerned, it is reverse panel. Panelists will be asking, and being a moderator, I'll be answering. And normal labor and high risk pregnancy, which are the legal consequences in this situation at the time of management? So we have very important panel, and I welcome all learned panelists who are going to bombard question to me. Dr. Monali Dole from Amravati, Dr. Lalita Lokhande Madam from Amravati, Dr. Samita Chaudhary Madam from Amravati, Dr. Saila Selke Madam from Sewagram Wardha, Dr. Rasri Madam from Nanded, Kishore Atnukar Sir from Nanded, Dr. Saili from Amravati, Dr. Sushma Tarak from Yawatmal, and Dr. Harslata Gainar Madam from Yawatmal. I also welcome all the President and Secretary of Joining Society and all the delegates who have joined this webinar. In era of COVID, I started this series with three friends, and my goal was to meet our Foxian friends on virtual platform to discuss focused topic and to be helpful to our Foxian friend, particularly to discuss some medical legal issues related to our day-to-day practice, not to get into it, and if at all, then how to get rid of it was the motto of this series. And I am happy to announce now it is 7,000 plus member family as far as this Happy Learning Masterclass web series is concerned. We have continued this working as far as this educational activity is concerned. So without wasting much of your time, welcoming you all to this 197th episode of Happy Learning Masterclass web series. Thank you very much.
Thank you, sir. I extend my welcome once again. And Piyush ji, if you would play the prayer, please. Please play the prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति
Namaskar. Now I would like to introduce the coordinators who've done Dr. Monica Umbardan, who has done so much of work to get this program together, and Dr. Rekha Rajendra Kumar, the current president of Bangalore Society, who's been a coordinator for a long time in this series. She is a practicing gynecologist for the last 32 years and has many awards and felicitations and is actually conducting multiple programs in such a very huge society very effectively. We have Dr. Monica Umbardan. She is a consultant obstetrician gynecologist at Mangalya Nursing Home and Athar Fertility Center. She is a PSC committee chairperson of AMOGS 2022 to 24. She is a website coordinator for MOGS, youth coordinator, executive member PAC, executive member ISOPAP, treasurer IMA, Solapur Obstetric Gynec Society treasurer 2015-16, then clinical secretary, then honorary secretary, executive member since 2014, and she is instrumental in designing the website and SOGS app. Welcome, Dr. Rekha and Dr. Monica. Now, may I have the CV of our guest of honor, respected Dr. Shakuntala Chhabra, ma'am. She is one person who really doesn't need any introduction. When I was a PG student, madam used to come to our place to take exams. Much loved, much feared. She is an MBBS DGO MD in obstetrics and gynecology from Nagpur University. She has a diploma in international maternal
Asha, you
health
don't
from
have
Sweden.
to. Asha, you need not.
Ma'am
take
is
time to
currently working as senior obstetrician gynecologist for Tapan Mukesh Bhai Patel Memorial Hospital and Research Center, Sherpur, Dhule district, which is run by Shri Vilepale Kelwani Mandal, Mumbai. Ma'am was the professor emeritus and was in Sewagram Hospital, and that is where we all know about her. So welcome, ma'am. We are really grateful to hear a few words from you.
A very good evening to one and all. My gratefulness to Dr. Patel, Asha, Monica, Rekha ji, and of course, I see the names of the persons. I will use the word my own people of the region. So I was so happy to see Poonam's face after many days. So my gratefulness to all of you, especially Dr. Patel for having called me some days back, and I told him I'm here and at a different place now. I will sure try to be there with you, and God is always there, and so I've been able to join. I think I have been with this program earlier from Melghat, and once I remember I had forgotten, and the moment I reached Melghat Hospital and I got a phone call from Dr. Patel, I said, it just during the travel, it skipped, but just give me a moment, I'll be with you. And because I had called from Sewagram, the laptop was ready, so there was no problem. So once again, my thanks. The subject, the theme is mixed bag, but in the mixed bag also there is something crystallized, which I really admired. You wrote because there's something where you're searching answers. There are gaps today, and there are certain things which will be always there and which are going to be increasing actually over the years. Hypertensive disorders of pregnancy, where I see the pathophysiology prediction is because globally research is going on, and I shouldn't use the word square one. We are advancing, but still a lot is left. And maybe it will be the next generation who will find answers to the question. And Poonam, I think, is going to speak about the management of eclampsia. And at times, if I remember, we get paid women at 26 weeks, 28 weeks, then nearing in labor also. And there are difficulties, what is right and what is wrong. And so management sometimes becomes very crucial, the decision making, because you have to think of the baby and the mother. And if you do Caesar in such patients, there is really more risk than vaginal birth. But then if you leave them also, there is risk, and also risk to the baby. So there are dilemmas, what is right and what is wrong. And I'm very sure with Poonam's vast knowledge of now, from her undergraduate level to postgraduate to the head of the department, and now as MS administrative aspects also, she will sure do justice to the subject given to her, and many others who are going to speak about the subject will enlighten. And I'm really sorry, I will have to leave because of local issues that the office has been kept open for me, especially because there is some Wi-Fi issue at my residence. So I won't be here. I'm extremely sorry. I'm apologizing from at this moment also. I won't be able to listen to everybody, but I'm very sure that the team is going to speak about pathology, pathophysiology, prediction, management, especially eclampsia. All of those who are listening will be richer in their knowledge, but will have questions also. because what more is to be done? This we have learned today, what more is to be done. The other aspect which overall I see is the legal issues in labor and overall high-risk pregnancies. Now, this is today a big problem. And this big problem is going to be bigger tomorrow because of information technology developing so much. Half knowledge is really dangerous. And this is where it comes to be, because people learn something from computers somewhere, and then they expect certain things. If that is not happening, they are wild without even realizing. And there are really dilemmas for the doctors, because finally we are human beings. We cannot see the future. We can take right decision at the right time. We try today, I should say, for the right thing, the right decision at the right time. But sometimes the decision is proved wrong retrospectively. Sometimes it is proved right. But it's the time which tells what is right and wrong. But we take, all of us are human beings, and we try to do best, thinking that, okay, if I do this, if I intervene, it is better. If I in labor, if I leave her alone, or if I induce, or if I augment, or if I give this medication, she'll be better. Same thing for high-risk pregnancies, whether to intervene or to keep pulled. These are dilemmas which will be, I'm very sure, are going to increase over the years. So the panel which you are going to have about this also, I'm sure people will get enlightened and will have some thoughts in their minds as this program ends at 8:30. And really, we, all of us, I always use the word, we learn till we get to our graveyard. And I always say, when the students ask a question, they become your teacher, because you start thinking, okay, this is also, when you are teaching, this is also to be seen in this. So with these words about the theme, and I would like to wish all the best to all the speakers. And I'm very sure they will help everyone who is part of this program to have richness in their knowledge. And I'm really sure also that they will have more thoughts for thinking for future better of women. Once again, my thanks to all of you, Dr. Patel, Asha ji, Monica ji, Rekha ji, and everybody. And all my best wishes. And I heard that it was 197 program. I really don't remember how many times I have been there, but I've been there quite a number of times. With these, I would like to thank all of you, and with my best wishes. And once again, I would like to say my real sorry for having that I will be leaving within few minutes. Okay.
Thank you. Thank you, madam, for sparing time. Just I mentioned prior also, your mere presence is enough to inspire us, to encourage us in this type of activity. And thank you for sparing time. We are blessed with your presence only. Thank you, madam.
Thank you so much. Thank you.
Ma'am is just joining. So I would like to thank you so much, Chhabra ma'am, for being with us and for blessing us. Now I would like to introduce Dr. Pushpa Jhungare ma'am, who's professor and HOD Gynae at PDMMC Amravati. She is a member of UG and PG Board of Studies of Surgery and Allied Subjects, member Faculty of Medicine, first visiting professor sent by Foxy to Cuttack, Odisha. She's a PhD guide. She has many awards and achievements. She has popularized NDVH in the Amravati region. She is instrumental in establishing the first human milk bank in central India. Pudkar Sanman Award in 2012-13 for working with HIV positives. Amravati District Best ICTC Award. Amog's Ratna Award. International MS Signature Award. One of the principal investigators in ESM Uterine Balloon Tamponade and PPH Bundle project in collaboration with Harvard University, USA. She has many national and international publications, authors chapters in obstetric gynec books, and one of the co-editors of Foxy textbook for PGs. Special interests are vaginal surgeries and obstetric emergencies. Welcome, ma'am. We would be blessed to hear a few words of blessing from Ma'am, you are muted. Kindly unmute yourself.
Good evening, madam. Good evening, all of you. Good evening, Shakuntala Chhabra, madam.
Good evening, very good
Good
evening.
evening.
I wanted to see
After
you,
a
so
long,
I
long
didn't
time.
leave you. I said I'll be there for 5 minutes before I go.
Okay.
Ma'am, we are waiting for your blessings.
Actually, Asha, madam, I am actually confused. That is what is my role today?
You are guest of
You
honor,
are our
madam,
guest of
to bless us.
Okay. Thank you very much, sir. It is a good thing that Dr. Asha, madam, and Dr. MC Patel, they are actually spreading knowledge through webinars. In fact, these webinars are so useful when we are not able to attend live CMEs or live educational programs. This webinars definitely can help, and we have a choice which to attend and which not to attend. So it is a very good endeavor by both of you, and it is always pleasure to join Dr. MC Patel sir's all the webinars. Almost, I think, now almost 3 years he is spreading knowledge by this way. And my best wishes for both Dr. MC Patel sir and Dr. Asha Jain, madam.
Thank you, madam.
Thank you so much, ma'am.
Thank you for sparing time, madam.
So with due permission, I think we'll
Oh, yes.
start the
Oh, yes.
scientific session.
Oh yes.
So may I have the CV of the chairpersons, please? So I would like to welcome Dr. Megha Ratnaparkhi, ma'am, who's a MBBS DGO from MGIMS Sewagram. She is owner of a private nursing home at Gondia and practicing for 20 years. She is also the immediate past president of Gondia Obstetric Gynec Society. Welcome, Megha, ma'am. We have Dr. Supriya Pandit Pedgaonkar. She is a consultant at Nanded since the last 18 years. She is also the secretary of Nanded Obstetric Gynec Society since 2023. Welcome, Supriya, ma'am. We also have Dr. Shefali Jain, ma'am, who's consultant and HOD, BJ Hospital and Research Institute, Ganesh Nagar, Gondia. She has worked as a consultant at GKNM Hospital, Coimbatore, ex-secretary of Gondia Society, present president of Gondia Obstetric Gynec Society. Her fields of interest are high-risk pregnancy, infertility, gynec clinic, menopausal health, working for public awareness in schools and colleges, lab training from Cochin under Dr. Hafiz Rahman, and ultrasound training from Mumbai. Welcome, respected chairpersons. I would request one of the chairpersons to introduce our speaker, the second to introduce the topic, and the third one to sum up the case. Over to you, ma'am, respected chairpersons, to take the program.
Ma'am, should I introduce Poonam, ma'am?
Yes, please
Yes,
go ahead.
Megha ma'am.
Yeah, it's actually honor for me, and it's a great pleasure to introduce Poonam Verma, ma'am. She was my teacher while doing DGO, and she has helped me a lot. She is at present, she is director, professor, and OBGY society. OBGY medical. She is also medical superintendent at Kasturba Hospital, MGIS Sewagram, Wardha. And she has done advanced training in SHRS from Uppsala University, Sweden, and she is training for EMOC CMC Vellore. She is core committee member of PPH working group PIGO. She is president Sewagram Wardha OBGY Society. She's principal investigator for.
We can concise this so that we can start the session. Just say a few words. That's it.
She is
No.
a great teacher. She is great human being, and she's she's very much interested in teaching all her students, and she is recipient of many awards from and presented many national and many papers and many lectures she has delivered in national and international conferences. Thank you, and over to you.
So can I begin with my presentation? Can I share my screen?
Yes, ma'am. Yes.
Yes, madam.
Is it visible?
Yes, madam. Make it slideshow.
Yeah, 1 minute. So a very good evening to all of you. Today, what I am going to present is the topic management of eclampsia. And at the outset, I would like to thank Dr. Patel and Dr. Asha Jain for giving me this opportunity. Sir, after that Webicon, which have been attended by more than 4,000 people, I think this master learning is becoming so popular that, students really wait for this to come so as they can learn so much. Thank you, Asha, for being there. And we all wish both of you the best of luck for your endeavors in the coming years. So with that, I bring greetings from Mahatma Gandhi Institute of Medical Sciences, Sewagram, an institute where I'm very proud to be, because this institute still follows ethics and evidence-based guidelines. This is our mother and child health wing, which we have created for the nation. And this is a model MCH wing, which is replicated by several states. Now, coming on to eclampsia, this is something which is a very dreadful complication of pregnancy, and all of us are really concerned about it. Eclampsia, we all know it's on the hypertensive disorders, especially preeclampsia. When seizures come in or convulsions come in, we call it eclampsia. Now, there are two words. My teacher was here. There are two words. One is eclampsia and another is eclampsism. When we say eclampsia, we are talking about preeclamptic women having convulsion. And when we are saying eclampsism, we are talking about a woman who had preeclampsia and directly went into coma. What are these convulsions? So there is a lot of controversy regarding this convulsions. So do they have to be generalized tonic-clonic convulsion, or shaking, jitteriness, disorientation, abnormal brain activities which are responsible for it? What do we take? And the consensus is that we should take tonic-clonic generalized convulsions as true convulsion when we talk in terms of eclampsia. Why does these convulsion happen? Because there's an abnormal brain activity, and this abnormal brain activity would be because of either cerebral edema, cerebral arrhythmias, and what happens is that there is a very small leak, or it could be a frank hemorrhage. So again, eclampsia becomes a very, very terrible condition when we talk in terms of neurological complications. Now, I'll talk a little bit more about the, the prevalence and what we are seeing and how many cases of eclampsia we are seeing. And then we'll go into the major topic. So eclampsia typically occurs after 20th week of pregnancy. If it comes before that, you have to rule out the other causes. There is varied incidence in different parts of world. 3% of people with preeclampsia have eclampsia globally. And in India, you would see the incidences, several research papers, they talk about eclampsia from 1 in 500 to 1 in 30. There are some places where you have it 1 in 30. And even in Maharashtra, there are pockets where we are finding too much of eclampsia. So why does this happen? I have already told you. And when we talk in terms of preeclampsia, we know that there is increased permeability of blood-brain barrier. This is the one which causes alteration in the cerebral blood flow. And due to impaired autoregulation and conversion, the whole problem of eclampsia starts. What are our concerns when we talk in terms of eclampsia? So one, it is an obstetric emergency. Women can die within few minutes or maybe some hour if not treated properly. And there's a very interesting word which has come in that is called obstetric transition. You will see that the pie chart of maternal mortality is becoming very different now. The PPH is constricting, and what is coming up is preeclampsia and eclampsia. So we all know that preeclampsia cannot be prevented because, as my teacher has always told me, there are prevention problems. There's always prevention issues when we talk in terms of obstetrics. So the transition, what is happening, that we are moving more towards ARDS, we are moving more towards sepsis, we are moving more towards some things which were there, but they are now expanding. So there's a transition, and eclampsia definitely comes under that transition. The major reason for morbidity and mortality for the baby and mother is due to eclampsia. And also, if we look into a normal patient and eclamptic patient, there's increase of perinatal and maternal morbidity and mortality by 3 to 4 folds. In 2019, there was a study where it has been seen that when we look into global prevalence of eclampsia, it is 0.3% of all delivery. And this 0.3% of all deliveries is not a small number when we talk in terms of India. Now, WHO also did multicentric studies, and they also did, survey of case fatality rate. And you will be surprised to see that case fatality rate has been as high as 8.3% when we talk in terms of the multicentric study, and 3.7% in the survey report. So I have already said that general consensus is tonic-clonic convulsion, but people have also used magnesium sulfate when they started seeing one hand moving or the other hand moving, and so on and so forth. Third trimester is the one where we have to be extremely careful in preeclamptic women, because that's the time when all the altered symptoms will start coming and the women will go into eclampsia. Always remember that in pregnancy, many a times, first time epilepsy precipitates, the cerebral malaria, meningitis and encephalitis, SOL, which is detected, tetanus now not anymore, and many other, differential diagnoses. So don't be bent upon that this is only eclampsia, but if you rule out these things, that also would be great, because many a time these conditions will present first time. So in my presentation, I'm going to discuss with you the classification, pre-monitoring symptom sign and high-risk factors, the first line of management, which we say 0R management, various regimes, obstetric management, a bit of literature updates, what has come up. So when we talk about eclampsia, we need to know the phases. The first phase is preictal phase, where warning signs are present, and you will see the moment you go to the patient, severe preeclampsia patient will start showing facial twitching, and she will, be very confused. You would be talking to her, she wouldn't respond. Second phase is the one which we are really concerned about, where, respiration stops, she aspirates and she dies. So generalized tonic-clonic convulsion, this stage is almost nearly, let's say, 40 to 60 seconds, each one of them. And then coming on to the phase 4, where it would be a post-ictal phase, where varied presentation has been seen. She either goes into coma, or she's confused and disoriented, and so on and so forth. Now, classification depending on the period of gestation where she had this: antepartum 50%, intrapartum 30%, and postpartum 20%. This is all given in the literature, and it continues so till date. What is very interesting is that generally after delivery 7 days, I mean, this is the period, within 7 days, you may have convulsion, but now we are seeing the convulsion even till 28 days. And this is explained, one, that your blood pressure has not been taken correctly. Second, there was some other cause, so it wasn't eclampsia. And third, transient hypertension is seen up till 6 weeks. So there is a possibility that transient hypertension was there, and therefore you had this eclampsia. And a word which we should never forget, which is very particularly for tertiary care hospital, is intercurrent eclampsia, where pregnancy continues for more than 48 to 72 hours or even more. And such cases, if the baby is preterm, they are very good because, the effect of the steroids come in. So what are the premonitory symptoms and signs of eclampsia? Or a woman going into eclampsia, we call it impending eclampsia. No more those words are used, but these are the warning signs. She will have severe kind of headache. She will have difficulty of breathing, sudden nausea and vomiting, which is persistent. She will go to pass urine number of times, but the amount will be too less. She'll have abdominal pain, mainly in epigastric and right hypochondriac region, blurring of vision, and of course, the edema, she would look full swollen women. So these are some pre-monitoring signs which will tell you that this woman can have eclampsia when she is severely eclampsia. There are also some high-risk factors where we expect that these women may undergo eclampsia. Because if age is more than 35, she's severely preeclamptic, there is a possibility. Elderly, preemie, and teenage, both extremes of ages, the complications are too much, possibility of eclampsia is there. Superimposed on chronic hypertension, these are the women who actually go into eclampsia, and these are the women who are very difficult to control. Antepartum preeclampsia, where the BP is resistant, not getting controlled. IVF pregnancy is the one which I'm seeing, and I'm telling you, we had a study of these IVF pregnancies, and we are seeing that 70% of them are having severe kind of preeclampsia. Non-compliant for drugs, associated comorbidities like diabetes and inadequate antenatal care. So these are the cases which could be high risk for eclampsia when they have preeclampsia. Now, there are some very critical cases of eclampsia where, even though you treat them, but the outcomes are not really very good. Long interval between onset of fit and commencement of treatment. And this is a very common thing because if you do not have system integration from PHC, CHC, the amount of time she takes to reach the tertiary care facility, this becomes a major issue. Antepartum eclampsia with long delivery interval, fits more than 10, coma in between the fits, temperature going very high, BP when it is more than 200 millimeters of mercury, especially systolic blood pressure, oliguria, proteinuria, which is more than 5 grams per 24 hours, the one who's refractory and not responding to treatment, especially the blood pressure when you're trying to control it, and if she has developed jaundice. How can we prevent eclampsia? This is something very, very important because I am telling you the major maternal mortality is because of the eclampsia, which can be prevented. We can't prevent preeclampsia, but we can certainly prevent eclampsia. Very good antenatal checkup, which is a quality checkup, not that it has been seen by only Asha and ANMs. It has been seen by doctors. It has been seen by a specialist doctor. And, in that Pradhan Mantri Yojana, we are all going to the PHC, CHCs, and we are able to provide our services, detect this early. Whenever you detect it, identify it early, have a proper evaluation and identify the major risk factors for eclampsia. And of course, the MACP regime, which is magnesium sulfate, a very well documented regime that it reduces almost 50% cases of eclampsia and severe preeclampsia. If you give magnesium sulfate, it does make a difference. Aspirin also, ASPRI trial and many other previous trials like CLASP trial and all, they have already said that aspirin 150 is also a prevention from preeclampsia or prevention from severe preeclampsia, which is a precursor for eclampsia. Now, this is something I would like to talk to you, that birth preparedness and complication readiness of the facility for managing eclampsia is extremely important. We say facility readiness. So when we talk in terms of facility readiness, or we talk in terms of birth preparedness and complication readiness, remember we have two sets. One is the patient and the relative, and the other set is emergency department and the specialized department. All four have to be ready for birth preparedness and complication readiness, and then only we can prevent preeclampsia deaths. So one, what is very important is to have obstetric rapid response team. We call it blue code, red code, but you should have a team which has not only junior resident doctors, the senior doctors, obstetricians, you have critical care consultant, physicians, whoever, but please have that team. And whenever you begin with the evaluation of women with eclampsia, always remember A, B, C, D, E. So we are no more ABC, we are A, B, C, D, E, and this prevents several deaths. So you look for airway, you look for breathing, you look for circulation, but also look for disability, which is actually neurological assessment. And E, where you look for environment, you look for hypothermia, you look for fluid deficiencies, and so on and so forth. So ABCDEs become very important. Counseling of patient and relative right from antenatal period, and especially if they have severe preeclampsia, what are the danger signs? When do they report? Where do they report? It's all very important. Very prompt emergency transfers and transfer protocol. So it's not important that you told, no, this is severe preeclampsia, she's going into eclampsia, or she has convulsion, please take her to some facility. It is equally your responsibility. And if you get into a medical legal case and you have not done proper transfer protocol, you're liable for a huge amount of payment. Why? Because one, the referral slips have to be completed. The transport has to be arranged. The accompanying person has to be there who should be with the capacity building. And not only, the facility sees that who's going with her, so relatives are coming. No, accompanying person has to be there who's well versed with the with managing the emergencies. And last but not the least, communication to the place where you are transferring the patient, so that that facility is absolutely ready with the stretcher, wheelchair, and the patient is taken immediately inside, and 0-hour management is most successful. So that is something very important. Readiness of triage is very important. And a word about triage. Nowadays, triaging, obstetric triaging has come up in a big way. And this has certainly reduced the deaths. And what is triaging? See, you have 10 patients standing outside, you are seeing, but you have to pick up that patient, which is truly a dire emergency. So there are red, orange, green, yellow. Those are the colors which you have to put the patient in to ensure. And at our setup, when we are seeing the patients, we are bringing them inside the triage. We immediately putting that color chips on the paper as well as on the records. So whenever there is a red chip, immediately people know that this is a very serious case and needs to be in HTU and ICU. And then what's most important is that everywhere you should have a PPH corner, you should have an eclampsia corner, where your eclampsia kit is absolutely ready. Your staff should be trained, and then of course multidisciplinary approach should be there. And when we say training of a staff, we are talking of taking plenty of emergency drills, simulation drills, which will exactly simulate how eclampsia patients come and what are you supposed to do. And these are great teaching to the postgraduate. Now, these are some kits which we are talking about. These are the main contents of eclampsia kit. You should have whiteboard cannula, the gray one and green one, IV drip set, Foley's catheter, IV fluids. You should have magnesium sulfate ampules 20% and 50%, calcium gluconate, syringes, all resuscitative equipments, instruments, and consumables. So your kit should be absolutely ready, especially in trial. Now, what are the principles of management of eclampsia? One, your infrastructure is ready to deal with this case. There should be triage, obstetric ICUs and HDUs for 24 hours and also 24 hours operation theatre. Your facility should be ready with all eclampsia kit and the capacity builded staff. 0-hour management resuscitation, I already told you ABCDE. There should be investigative facility because these are the ones, if they go into ventilator, they will need ABG as well. Medical management should be given with lot of caution, but immediately to abort convulsions and prevent recurrence of convulsions. There's some general management which has to be given, and then obstetrical management should be done safe and timely. There should be strict supervision and monitoring and future follow. So these are the infrastructure, just showing you what we do here. So we have infrastructure here. And as I told you, these are 4 basic things which are required along with OT to deal with eclampsia cases. Now coming on to 0-hour management, the moment women comes to you, first thing is call for help because this women cannot be managed alone. You've already started ABCDE, you have secured the airway. You have to prevent tongue bite and by using a mouth gag or something and prevent injuries because when she convulses, her hands move and many a time suction machine is there and she breaks her bone. So you have to ensure that everything is moved away from her. She is on a very special cord. To minimize aspiration, the lateral decubitus position and oral suctioning would help. Oxygen saturation has to be maintained by giving oxygen. And then you have to catheterize to see how much is her urine output because you have to give magnesium sulfate. Then secure 2 lines which are wide bore cannulas, and at the same time you take the sample for a special investigations like CBC, LFT, KFT, and coagulation profile. Quick history and rapid initial assessment is mandatory. And the moment you find that everything is good, please initiate magnesium sulfate in triage itself. And then after the initial assessment, shift her to eclampsia. Now, what are the investigations we are supposed to do? So these are similar investigation what you do in preeclampsia. The platelet counts, KFT, LFT, where you look for the creatinine and your ALT/AST, blood coagulation profile, electrolytes, and of course the routine investigation which everyone does. The frequency of investigations is a stat, and then on alternate days as you give her magnesium sulfate and she delivers. But this women will take slight time because as ma'am used to tell us that kidneys are shy and they are the first organ to get affected. So it will take time for the creatinine to come down. So don't be in hurry to send her for hemodialysis. And then, of course, the ophthalmoscopic examination, ECG, etc., if it is required. For fetal assessment, it's immediately NST, USG with Doppler, and biophysical profile there and then, and you decide for the obstetric management. Maternal CT is only done after delivery if the convulsions are persistent. And if she has a status epilepticus where the woman is deteriorate. So coming on to the medical management, we will prevent convulsion, we will reduce her blood pressure, and we'll give a very specific fluid therapy. So to prevent convulsions, we all know all the regimes, Lee's regime, diazepam regime, which used to be the Eliticote, all that have gone. The only drug which is accepted is now magnesium sulfate. And profile-active magnesium sulfate is very effective in 50% prevention of cases of eclampsia. MACP trial very clearly says. How does this particular drug act? It reduces presynaptic release of neurotransmitter glutamate. It blocks the glutamatergic N-methyl D-aspartate receptors and prevents convulsion, potentiates the adenosine action, and it blocks the calcium entry. So again, the convulsions are prevented. So what are the various regimes we are using? All of us know we are doing, or we are all using Pritchard regime. But what is very important in Pritchard regime? 4 grams of 20% slow IV over 5 minutes, then 10 grams of 50% solution, 5 grams in each buttocks IM in the upper quadrant. Some people are using 2% lidocaine because this is a painful injection. If convulsion persists after 15 minutes, you can give one more dose of 2 grams intravenously of 20% solution. And then every 4 hours, you give 5 grams of 50% solution deep intramuscular in alternate buttock. Now, what is very important here is that one should know how to make 20% solution. We have seen people giving 50% solution IV also. No, that is not to be done. You have to make. So the people should know that you have to add 8 ml of the magnesium sulfate ampules, 2 ml. So 4 ampules, 8 ml. And in that, you have to add 12 ml of distilled water to make it 20%. So what is very important that everyone should be taught how you are going to make this 20% solution, because these ampules are mostly not available. There are many other regimes.
Poonam ma'am, I
Yeah.
would request you to speed it up. It was supposed to be 20 minutes. It's already half an hour.
Okay, I'll just finish in 5 minutes. There are Juspans and Dhaka regimes which are there. I won't go into details, but Juspan's regime is used because you give 4 grams IV and then 1 gram IV per hour, which is given in the infusion pump. Sibai regime, Dhaka regime, which is low dose regime, are also being used. So supportive care for patients of magnesium sulfate, as I told you, we have to check for respiratory rate, urinary output, and patellar reflex. And if they are proper, in the sense that your respiratory rate is normal, output is okay, then you can go ahead with the further therapy. So it is given for 24 hours after delivery or after convulsion, whichever is the first. Toxicity, as I told you, these are magnesium concentrations where more than 12 serum magnesium leads to cardiac arrest. Treatment for toxicity is calcium gluconate, rule of 10, 10%, 10 minutes has to be given. So this is about your medical management. Antihypertensives, very clear now that the BP has to be 135 over 85. That's the aim of BP control. CHIPS trial has clearly told us. Injectable labetalol is the drug of choice. So 20 milligram IV, then wait for 10 minutes, 20 again, then 40, 80 like that. So total, you can give nearly 160. Hydralazine regime is there, but we are not following it. And oral therapy is given once the women has come out of it. Finally, coming on to obstetric management, then eclampsia is not an indication for cesarean section, but certainly we have to look into certain things because this is the treatment. Actually, delivery is the treatment. Rapid steroid doses are to be given. And of course, all the 3 stages, you have to see that it should not be prolonged. And all what you have to see that please do not give methergin or prostadine unless they are indicated or she has PPH. So this is what has to be done. Intercurrent eclampsia is to be practiced only in medical college. Fluid therapy is very important because the women, if you infuse too much fluid, she'll die of dilutional coagulopathy. So 300 ml, 300 ml, if required blood, but do not infuse her with too much of fluid because she may have pulmonary edema as well. Strict supervision, looking for respiratory rate, patellar reflex, and urinary output. Any bleeding, changing vitals, you have to report immediately. My last 2 slides, status eclampticus is also something. Now, this is one condition where you need anesthesiologist and critical care consultant because you need to give thiopenton sodium and diazepam in such cases. Future follow-up, we all know that 25 to 30% of them will end up in chronic hypertension. So they need to come for regular checkups, and 3 to 10% will have some or the other kind of cerebral morbidity if CT has been seen to be positive. These are two literatures which are talking about, giving how to give magnesium sulfate, what are the different ways, and do we really need to look into the urinary output before giving doses. So please go through these two. And my take-home messages are that it's an obstetric emergency, it is preventable, quality antenatal care, early identification, good system integration and facility readiness and teamwork, and of course the capacity building. How to give this wonder drug will save the women. Thank you very much for your patience here.
Okay.
Thank you very much, Poonam Madam. It was really a wonderful talk. You have highlighted almost everything regarding the eclampsia. But one thing I want to discuss here, that when we were student, eclampsia was very rampant and very common. I mean, there used to be a separate ward for eclampsia patient. And that's why all the PG students and the obstetricians before 20 years or 15 years, I can say, they were mastering in managing the eclampsia, correct? But nowadays, even the government is very particular about the antenatal care. Then there are multiple private practitioners, there are many institutions, and that's why the chances of this hypertensive disorders and specifically eclampsia, they are very lesser nowadays. And that's why the patients are also lesser. So most of the newcomers or the new the obstetricians, they are not that much, experienced regarding the eclampsia. Only one thing, very important thing, what practically we should follow, that every time we should use the same magnesium sulfate ampule in your hospital. One should not change. And second thing, expiry should always be changed because the patients are very rare in the hospital. And whenever such patient comes to the hospital, in many hospitals, what I have seen, that most of the ampules or the medicines, they are expired. And that's why the tray should always be ready. It should be always checked that the expiry of the drug should not be there. And every time the same concentration or same company product should be used, so that the subordinates or the people who are working in the hospital should be like aware about the concentration and how the drug should be made. Because when the patient is in eclampsia, the doctor, the primary doctor in the private hospital, they themselves are panicked. And that's why many times they are not that much the people who are helping them, they are not that much compatible. So they should be aware, or they should be taught, or there should be like rehearsals for the preparation of the solutions or the magnesium sulfate, these drips and everything should be done. So this is the take home from my side.
Thank you, sir. So I have a confession to make to all the viewers. I made a jumble up, and Dr. Girish sir and Dr. Anil sir were supposed to chair this session. And
Madam, unmute yourself.
yeah, so I did not introduce you. Sir is the past chairperson
No, madam, it's okay.
Committee.
It's okay. Madam, it's okay.
And yes, sir. And Dr. Anil Sakhre sir is the president of Nanded Society. Anil sir, if a few words from you as well, and then I will take the others in the next session. Anil sir, are you there? Thank you, Girish sir. Thank you so much.
Thank you, madam. Thank you.
Yes, sir. A few words from you as well, sir, because you both have an engagement after this. So if you would like to say a few words about eclampsia.
Yeah, madam, Poonam ma'am has elaborated very nicely. Actually, this lecture should be for all postgraduates, a complete package of how to manage these eclampsia patients. Though we are claiming that the eclampsias number is decreasing, but what my personal opinion is that though the number is decreasing, but the complications in such patients are increasing.
Yeah.
So we should be always, So many times particularly sudden postpartum collapse and all these things are very common with such patients. So we should be always ready. And as madam suggested that the mock drills is a key role, will play a key role in the institutes, that everybody will be get ready with such mock drills, and we can save the life. Even we can really save the patients, really save the near miss mortalities in eclampsia patients. Thank you, ma'am, for such a wonderful deliberation of this eclampsia.
Sir, one question to MC Patel, sir.
Yes.
Sir, in a patient of eclampsia, if I am my anesthetist is comfortable to give spinal anesthesia to the patient, and if he or she is giving spinal anesthesia, and we are, I mean, succeeded for giving that anesthesia, and something goes wrong, and because of some other reason, if the patient succumbs, so is there any blame on the anesthesia in such cases?
So in
Or
any
general
case of,
anesthesia is mandatory?
not eclampsia, but in any case, when you have more than one school of thoughts, you are at liberty to choose any one of them. Because in famous case of Jacob Matthews versus State of Punjab, in Supreme Court, when this case was decided, it was mentioned by Supreme Court also. When you have one then more options, you can choose any one of that very option. But whatever you choose in that very given situation, it should be best available to that very patient, and it should be as per standard medical norms. In this situation, is spinal anesthesia better or is general anesthesia is better? As per standard textbook, as per practice prevailing in nearby medical college, as per practice prevailing in peer groups, that way you have to manage. So allegation could be anything or to anybody. Even patient party may make anesthesiologist also party. It is not necessary that when it happened under your roof, being a gynecologist, it will be solely to you only. Patient's party may make a party, anesthesiologist or any other doctors who have involved in treatment. They can be made a party. But we have to justify our role. What we did in that very given situation, how we managed that case in that very given situation. Or in short, we can say, did we manage that case way in which any prudent gynecologist would have managed in that very given situation? If we can justify this, then we could be out of problem.
So because post-spinal hypotension is very common, and as soon as the baby is taken out in the eclampsia case, many people, they says that general anesthesia should be preferred, but unfortunately in most of the obstetricians, the arrangements of the general anesthesia, they are most of the time they are lacking. See, because most of the cases we are doing, they are under spinal anesthesia. Many times the drugs are expired. Sometimes some drugs are not, available. Sometimes that even those small instruments, for endotracheal intubation and all, they are not working. So in such cases, spinal anesthesia can be, because we had one debate on this, and that time somebody was saying that till you are doing good with spinal anesthesia, it's okay. But after giving spinal anesthesia, if your patient is getting some problems with that, then it can be problem, or it can be havoc for the anesthesiologist as well as the obstetrician. And that is
the problem. What happens is when you are giving a spinal anesthesia, and why you are not giving general anesthesia, even in the tertiary colleges, sir. General anesthesia is given because, you want to deliver the women very fast. For spinal anesthesia, to prevent postpartum collapse, you need to preload her. And preloading is an issue because you don't have time. And that's the reason why people are really going. But many of the eclampsia cases which have been not that bad as far as fluid challenge is concerned, you give spinal anesthesia. It's not an issue because slowly while you are doing section, they preload. That way.
I want to know what law says.
Yes, I am coming to
that. Law says that you can use whichever.
It is very common dictum. Law doesn't teach you medicine. How to manage patient, that is up to us. But whatever we do in that very given situation, we should be in a position to justify our action. And in this situation, a court takes into consideration where you are practicing, in which resources you are practicing. Because just mentioned by Dr. Poonam Madam, if you are in a tertiary, a remote place, and where limited facility is there, and whatever you do in good faith of patient, it is always pardoned and it is always in your favor. But you have to justify that whatever you did, it was as per standard medical norms, and in that very given situation, you could have done this one.
Thank you.
Yes.
Thank you, sir. We are
May I
really
take half a
running
minute?
very, very late. Very late. Yes, ma'am.
Yes.
This is question for Dr. Poonam. There is ready to administer magnesium sulfate, that is 4 grams in infusion. So have you having any experience regarding this?
Ma'am, we have tried this Juspan regime in number of cases. There was
the bolus dose, first dose, that 0 hours. This is commercially available. 4 grams in 100 ml of
We
fluid.
haven't used that. We have always prepared it by 50%. So because here people are very poor, they can't get those ready to do whatever is available in the hospital. So we have prepared it from 50%, not use the ready.
Yes, we also do it, but we sometimes do give it in 100 ml normal saline. It is given then very rapidly. That is 100 ml hardly takes 15 minutes. So
No,
instead of giving by
don't have
bolus
experience
syringe.
of that, ma'am. We are doing with 50%, making it 20%, and then giving IV. So we'll see if there's something like this available and what is the cost for us.
Asha madam, last sentence for eclampsia from me. Me and Dr. Rashmi, we are privileged to have our great teacher, Dr. Somanshi madam here with us, who taught us the management, diagnosis of eclampsia and everything. And whatever we are practicing only because of Pushpa madam. Thank you, madam. Thank you very much.
Thank you, sir. Sir, me being the convener, my concern is time. I'm really sorry because I have to finish the program at 8:30.
Okay,
So
okay.
we now proceed
You
to
can
the second
proceed.
lecture.
Okay.
We proceed to the second lecture. May I have the CV, please?
Thank you, Asha madam. Thank you, Asha madam. I would like to share the screen and start.
Just a second, Dr. Rashmi.
Nene.
Just a second. So before this, may I have the chairperson's CV? I haven't gone through them. Yeah. So Suyoga Panat ma'am is a consultant obstetrician and gynecologist, chairperson of AMOG's Medical Legal Committee, West Zone Coordinator, Ethics and Medical Legal Committee. She has very many awards and she's the Joint Secretary of AMOG's. Next, please. Welcome, ma'am. We have Dr. Girish Mane, sir.
Thank you, ma'am.
Who is past chairperson of Adolescent Health Committee, FOXY, past chairperson of Adolescent Gynec Committee, AMOG's, past president of Yawatmal Obstetric Gynec Society. And you've all heard how well versed he is in managing obstetric cases, has so many awards
Thank
and
you, madam.
publications. Welcome, sir.
Thank you.
We have Dr. Anil Sakhre, sir, who has worked as assistant professor at GMC Nanded for 11 years. He's an UG and UG teacher and PG teacher and examiner, has many publications, has contributed to Williams textbook of obstetrics. That's great. Namaskar, sir. Contributed to operative textbook of Cunningham. Again, these were our two Bhagavad Gitas, with the third one being Hutchinson. So we are really honored to have you here with us, sir. I understand I made a mix-up. Now I would request any of the current chairpersons, I've introduced everyone, to introduce Rashmi Kahar, ma'am.
Madam, may I?
Yeah, Suyoga, you are the rightest person for that.
Yes. Actually, it's really a proud moment for me to introduce our president of Amravati ObyGyn Society and
we
my
want
friend,
to know
Dr.
about
Rashmi
her
Kahar.
other than what is written in the slide.
Other than what is
Sir,
written
I
in
told her to display it, and I don't know if she's done it.
Yeah. She is and was the chairperson of High Risk Pregnancy Committee of AMOG's, and she's doing a wonderful job. She has a lot of work
Thank
to
you,
do in
Suyoga.
her hand.
I'm all yours. Thank you, Suyoga. Thank you so much. I'm all yours.
Thank you. Over to you, Rashmi.
So my regards and my pranam to my chairpersons and my teachers, Dr. Pushpa Jhungare madam and Dr. Poonam Verma madam, and my special thanks to respected Dr. MC Patel sir for giving me this opportunity, Dr. Rekha Rajendra Kumar madam and respected Dr. Asha Jain madam. I would like to seek permission from my chairpersons, Dr. Girish da, Dr. Anil Sakhre sir and Dr.Suyoga, and I would like to proceed with my talk. Good evening, everybody. I'm Dr.Rashmi Kahar, and I will be talking on hypertensive disorders of pregnancy, overview, and pathophysiology.
Rashmi, make it slideshow, please. Thank you.
So in next 12 minutes, I will be talking on what is the epidemiology of HDP, classification of HDP, pathophysiology of HDP, risk factors, new insights into HDP, and the summary. So as we all understand, in 2014, WHO has declared that hypertensive disorders of pregnancy is the second most cause of maternal mortality, first being hemorrhage, as we all agree. Near about 76,000 women die each year worldwide due to HDP, and that comes to about 200 women per day dying due to hypertensive disorders of pregnancy. In India, 1 in every 15 to 1 in every 50 patients, pregnant patients who comes to our OPD poses with a very high risk of HDP. And it is affecting 2 to 5% of pregnant women. Developing countries like ours has 7 times more risk of developing HDP in pregnant women as compared to developed countries. In India, we have many studies in collaboration from various associations like NRHN, RCH, FOXY, Justosis. They are done on HDP, pertaining to why there is such high prevalence of disease. And now ICMR has very clearly said HDP and hemorrhage constitutes about 51.10% of the disease burden in pregnant women. So high prevalence of HDP points our attention to 2 important factors. The first being it amounts to majority of deaths in peripartum and immediate postpartum period, which is a matter of great concern to all of us. And second point is that if there is early detection of this disease, it will help us in preventing its complications. Thereby, we will be able to minimize the major disease burden of this disease in our country. As we all agree, we may not be able to halt the disease process, but yes, we can prevent it to some extent. So talking about the classification of HDP, I know after Poonam Madam's talk, this is a very basic talk, and please excuse me if there are some overlaps also. So any rise of blood pressure more than 140 systolic and 90 millimeter diastolic of mercury is said to be the patient is said to have HDP. And proteinuria is not mandatory in the diagnosis of HDP. When this rise of blood pressure occurs 20 weeks of pregnancy, we call it as chronic hypertension. It may be essential, de novo, or secondary to some other cause. And when this rise of blood pressure is after 20 weeks of pregnancy, we call it as gestational hypertension. And gestational hypertension is without proteinuria. So in a patient whose blood pressure is more than 140 by 90 millimeter of mercury, she is pregnant more than 20 weeks. And if there are features of proteinuria or there are any signs or symptoms suggestive of maternal end organ dysfunction like edema, headache, and if there are signs or symptoms which suggest uteroplacental dysfunction like IUGR, small baby, etc., and there are some placental angiogenic imbalances seen in the mother, then we call this condition as preeclampsia. And when convulsions add to preeclampsia, we label it as when convulsions add to preeclampsia, we label it as eclampsia. So as we can very clearly say, there are some definite superimpositions in all these conditions in HDP. So there are 2 more important conditions other than chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and superimposed hypertension. And these 2 are white coat hypertension and mask hypertension. So white coat hypertension is the one, the patient when comes to the OPD of a doctor, her blood pressure is on rise. When she goes home and if she checks her blood pressure at home, the blood pressure remains normal. Mask hypertension is a term that patients, when she comes to the OPD of a doctor, OPD of the ObyGyn, her blood pressure is normal. But the relatives will say that when she is at home and they check her blood pressure at home, it was high. So The significance of these two conditions is that these two conditions are going to catch us off guard. Why? Because we will think that the patient might have normal BP or it has increased only on one incidence. But these two conditions will remain masked, will catch us off guard, and will definitely pose with complications in later pregnancy. So because it is the disease of high blood pressure during the pregnancy, it is very important to take the correct measurement of blood pressure. The sphygmomanometer should be correctly calibrated. It should be, we can take record the BP by automated device. The cuff size should be correct. The patient should have evacuated her bladder before recording the blood pressure. The patient's position should be correct. And recording on either arm during each visit while recording blood pressure is important. Say for her example, her blood pressure is more than 160 or 110 millimeter of mercury. It should be repeated in 15 minutes and then only confirmed. If blood pressure is less than 160 by 110 millimeter of mercury, it should be repeated after a few hours and then confirmed. Proteinuria is not required for diagnosis of HDP, but it should be defined when present. It should be more than 30 milligram per millimicromole. Protein creatinine ratio should be more than 0.3 gram per deciliter in 24 urine sample, or it should be more than 2 plus by urine dipstick method. So coming to the pathophysiology of hypertensive disorders of pregnancy, we always say and we always agree that HDP is a disease of theories. This is the most enigmatic disease and nobody could have been exactly pointed out or reached to the causation of this disease. The disease of enigma, because as we know, there are changes in normal pregnancy. In the first 20 weeks of pregnancy, there occurs remodeling of spiral arteries. Why? Because we want the baby to get good blood supply. Vascular endothelial and smooth muscle cells of spiral arteries are replaced by fetal trophoblastic cells. And this causes increased blood flow to the intravillous space and thus increased blood supply to the developing fetus. So what happens in HDP? There is no trophoblastic invasion proper. And this failure of remodeling of spiral arteries causes reduced placental perfusion. This reduced placental perfusion induces systemic vascular dysfunction, resulting in placental hypoxia, and a cascade of inflammatory events start. And it is very well said by two-stage theory of preeclampsia. The stage 1 is before 20 weeks of pregnancy, and at this stage occurs a very defective cytotrophoblastic invasion into maternal uterine spiral arteries. It is shown after the result becomes evident or revealed after 20 weeks of gestation. After that 20 weeks, there is hypoperfusion of placenta, releasing anti-angiogenic factors like SFLT1 into maternal circulation, which induces generalized endothelial dysfunction and a systemic vascular dysfunction. So what happens in stage 1? So there is abnormal placentation. It is aided by risk factors like some genetic risk factors, environmental risk factors, immunological factors, or metabolic factors, leading to abnormal trophoblastic invasion. The spiral arterial flow is decreased due to narrowing of arteries, resulting into placental ischemia and hypoxia. And after 20 weeks, it is revealed as there is very sharp decrease in pro-angiogenesis and decrease in anti-inflammatory factors like PIGF and VEGF. And anti-angiogenesis and pro-inflammation along with endothelial dysfunction occurs, and it is evident by increase in SFLT1 and SENG. This leads to systemic dysfunction. There are some important angiogenic causes like abnormal placentation induces ischemia. Ischemia causes release of pro-inflammatory and anti-angiogenic proteins like SFLT1 and endoglin. They both bind to PIGF and VEGF, which are angiogenic factors. This completely disrupts the angiogenic balance and leads to endothelial dysfunction. Endoglin is a placenta-derived subtle soluble TGF co-receptor, and SFLT1 and endoglin, they act synergistically to bring about anti-angiogenic states. To add to this, there are immunological factors Because we know peripheral blood NK-cells and residual DNK-cells, they are significantly higher in both early and late preeclampsia during labor, and this suggests that they have a role in spiral remodeling of arteries in the early stages and also at the late stages. To add to these causes are the oxidative stress caused to the abnormal placentation causing inappropriate spiral artery remodeling, leading to placental ischemia, damage of proteins, lipids, and DNA, causing oxidative stress, leading to pro-inflammatory and anti-inflammatory cytokines, and completely bringing about endothelial dysfunction. So this abnormal placentation, which causes ischemia and excessive oxidative stress, releases placental debris and vesicles into maternal circulation. They interact with maternal endothelial cells, and there is transcriptome alterations and profound inflammation in maternal vasculature. The endothelium of maternal organs is affected, and all the organs of mother are affected due to HDP. Say, for example, hypertensive disorder of pregnancy. When it affects the pulmonary circulation, the patient will present with pulmonary edema. When it affects and brings about hypertension, patient's blood pressure will be rising. When it affects the fetus, the baby will result into IUGR or small for growth baby. When it affects the renal system of mother, there will be acute or acute on chronic renal failure seen in a patient of complications of HDP. When it affects the brain of mother, we will see that the patient is having convulsions or visual disturbances. And when it affects the cardiovascular system of the patient, we see that the patient may have chronic hypertension later in her pregnancy. And when it affects the circulatory system, we see that the patient, when lands into complications, may land into DIC. So this is the HDP score, and it is very useful for prevention and screening of the patient. It is very simplified, reproducible, and systematic quantification of maternal risk factors. And it is very useful for us, like low and middle income countries. This easy-to-use score can be used for screening and prediction of preeclampsia. It involves all the existing and emerging risk factors in the pregnant woman. And a separate score of 1, 2, and 3 are allotted to each clinical factor. When this total score is equal to or is more than 3, the patient should be marked as at risk for preeclampsia. And these are the risk factors clearly seen, like the woman who herself was born as small for gestational age, maternal anemia, age more than 35 years, age younger than 19 years, obesity, nulli gravida, short duration of paternity, that is cohabitation, family history of preeclampsia, family history of cardiovascular disease, PCOD, and so on. The significance of gestational score is that we can mark the HDP at-risk patient very conveniently, and it gives, this gestational score gives weightage according to the severity. It allows some points to be kept blank if they are not presenting as risk factors in the mother. This can be done by any healthcare worker easily. And for prevention of HDP, we use aspirin 75 milligram at bedtime, and along with elemental calcium 1 to 1.5 gram in divided doses, and we recommend low carbohydrate, high protein diet. There is no need of salt restriction, but no excess salts are allowed. So what's new in learning of HDP? So now we always say that consensus has, since centuries, it has agreed and it favors the hypothesis that placenta or faulty placentation is the primary risk factor or is the causative mechanism for development of HDP. But scientists have researched, and there are inquisitive researchers like Monica Umbardan. You are in the webinar. She will ask, she has many questions. She will ask, is really placenta villain, madam, as you say? Is placental ischemia is the cause of HDP, or placental ischemia is the result of HDP? Is the placenta as such a villain or is a victim? Is it the causative agent of HDP or placental ischemia is the result of HDP? What's new in learning HDP? So now we have emerging evidence that placental ischemia may not be the causative factor for HDP. We have emerging evidence that suboptimal serious cardiovascular performance in a woman may cause uteroplacental dysfunction, may cause decreased uteroplacental circulation, leading to placental ischemia. HDP and cardiovascular dysfunction go hand in hand. See, we have started using antihypertensive drugs very effectively in the management of HDP, like statins, aspirin, antihypertensive agents. Then, moreover, some risk factors, which are the risk factors for HDP, are similar to the risk factors of chronic cardiovascular diseases. So we can say that we have many opportunities to think about it, and there are many opportunities to research who is the causative agent and who is the villain or victim. In short, HDP should be treated in a very broader perspective. It is not the disease of increased blood pressure only. It is going to affect each and every organ in the mother and fetus. It's a spectrum of clinical conditions which include multiple organs of both mother and fetus. HDP has both long-term and short-term complications in both. And what is important, what I learned while preparing this talk, understanding pathophysiology gives very important clues about prevention and treatment of this disease. And this is an area very ripe for research and further studies as far as treatment modalities is concerned. Thank you very much.
Thank you very much, Rashmi. As usual, you have enlightened every aspect of pathophysiology. That gestosis score, I think we should mention the name of Dr. Gorak Mandukar, our dear friend. And we had one program for all the medical officers in Yawatmal, along with this DHO office and civil surgeon office. We gathered all the medical officers of Yawatmal district on one dais, and we had one live session. I mean, we prepared some tables, and we had one-to-one discussions with all the medical officers. And Dr. Gorak and we all people, we taught them everything about the gestosis score. And we are very happy to inform you, all of you, that most of the medical officers, they are using these scores very regularly. They have printed the charts and they are utilizing in their practice. And many patients, they are very easily, they are chalked out at the level of primary health care center, and they are referred to the higher centers like or private hospitals or government hospitals. So gestosis score is really a wonder, and thank you very much all the members of gestosis for that great achievement. And you have really done a good job. Thank you.
Thank you, Girish. Thank you very much. Asha madam, I hope I finished in time.
You actually finished in time and before time. So we still have an hour left for the panel. Thank you very much. Anybody has any questions of Dr. Rashmi? Otherwise, we proceed to the panel.
Two other chairpersons, Shefali Jain and
Shefali ma'am has just left. She had an emergency. And Suyoga ma'am is here.
Megha madam was one more chairpersons.
Megha ma'am is here. She actually introduced the first chairperson. So,
is there any comment from her?
Brilliant talk by Dr. Rashmi, and she has elaborated each and every detail about the pathophysiology, and I hope it will be really helpful while treating the patient and while understanding the reason of hypertension and also the implementation of gestosis score in our day-to-day practice. I thank Dr. Rashmi as well as I thank Dr. C Patel sir and Dr. Asha Jain madam for this opportunity, and I wish all the three of them best wishes for their upcoming elections. Thank you, sir.
Thank you so much, Dr. Suyoga. Thank you.
Thank you, Suyoga.
Thank you, Dr. Rashmi. Dr. Rashmi is in the middle of another webinar and she came and gave her lecture. So kudos to you, ma'am. Thank you, Girish sir, for being with us.
Thank you, madam.
And now I would like to take the program forward and the panel today is a reverse panel on legal issues in labor and high-risk pregnancy. So now I would like to formally introduce Sir. He doesn't need an introduction, but it's still a privilege to introduce him. Sir is a consultant obstetrician gynecologist and medico-legal counselor. He was VP Foxy 2018, organizing secretary AICOG 2017, chairperson Ethics and Medico-Legal Committee Foxy 2011 to 13, honorary secretary SOGO 2022 to 24, organizing chairperson MMCon 2018, honorary member National Inspection and Monitoring Committee PNDT at Government of India 2015, and many other things. More than this, there are 2 or 3 points that I would like to say extra about him. Sir has a very consistent approach to anything that he is doing. He started being the chairperson of Ethics and Medico-Legal Committee in 2011, and he never stopped helping gynecologists in their medico-legal needs to date. For the last 21 years, he's been going to the Northeast, giving health care to the underprivileged ladies there at least a week every year, again 21 years. So, and this program is 197. So consistency, dependability, approachability, these are all his assets. So welcome, sir. Welcome to this webinar. Sir is also going for Foxy President this year. Voting will be 10 a.m. 1st August to 5 p.m. 10th August. Please do vote. Now, here is a short video from Sir. Sir, is the audio audible?
Shubham karotu kalyanam Arogyam Sukha Sampadam.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
That's me. I've been introduced. I request your voting for Foxy Food, Drug and Medical Surgical Equipment Committee. Voting is 16th to 25th August. Now I would like to welcome all my panelists to this webinar. I shall be introducing them as they come along. So before we start the program proper, sir, I want to ask you, everybody knows that labor has its complications. There are no guarantees. So are medico-legal problems in labor worth discussing?
Naturally, yes. Because in era of this CPA and criminal litigations, now medico-legal consequences are increasing in number constantly and steadily. And unluckily, we gynecologists rank first. If we go with statistic of medico-legal consequences, total number of cases faced by our medical fraternity, 29% shared by gynecologists, followed by orthopedic surgeon, 22%. because we are dealing with two lives, mother and baby naturally. So it is very potential condition as far as medical legal consequences are concerned in labor or in any surgery or any procedure related to our obstetric practice or gynec practice. These are the potential areas. That is why this is worth discussing as far as legal issues in normal labor as well as in high risk pregnancy are concerned. Yes, next.
Madam, please unmute yourself. Asha ma'am.
Thank you. Now I would like to welcome Dr. Monali Dhole, who is the Secretary of Amravati Obstetric Gynec Society with laparoscopic and infertility training, to ask you her question. So over to you, Monali ma'am.
Yes, sir. Thank you, ma'am. Thank you for the nice introduction. So why the litigations are common related to pregnancy and labor? As you said, there are more litigation in our field.
Because in this group, pregnancy related, usually they are young patients. And usually they are book patient. Of course, there are few cases are there. They are brought in emergency, but otherwise they are book patient. And usually this group of patient comes on foot to your hospital. Of course, there are very few patients which are brought in an emergency in ambulance or so, but otherwise young patient comes on foot, book patient. So mentally, patient and patient's relative are not prepared to face any misfortune occurs if at all during treatment. So these are the cases. And just I mentioned prior also, we are dealing with two lives, mother and fetus. So litigations are very common in this type of situation. And when we are assisting birth by some procedure, say for example, external cephalic version or internal pudilic version or forceps delivery or vacuum delivery or cesarean section. So any complication related to this are potential conditions as far as litigations are concerned.
Could you give some specific landmark case in this so that it can be helpful for the gynecs?
In that very case, it was pregnancy, patient was conceived by ART treatment, and it was very regular visit with this gynecologist. Every month she used to come to gynecology. Every month sonography was done, and every time she was told that everything is fine except mild polyhydramnios. But at 34 weeks of pregnancy, during routine antenatal checkup, it was found that it was case of intrauterine fetal death. So cesarean section was advised, and all necessary investigation before cesarean section were advised. And in that very investigations, blood sugar came out to be 432 milligram per dilution. So, and it was never done before. So before 34 weeks of pregnancy, if one do not advise to go for blood sugar, it cannot be pardoned in this modern era of obstetric and as well as in CPE. So in this, case was filed. Of course, case is still pending, you have to decide. But case was filed and compensation of worth rupees 2 crore is demanded. An allegation to that a gynecologist by patient because she conceived with ART treatment and after she delivered SB child, it was male child. So they have an allegation that if this child would have been live, it would have been our help in our old age. So that way they had filed a case. Of course, case is yet to decide. But in this type of cases, very common reason for allegation or litigation is not advising proper investigation, particularly in high-risk pregnancy cases. Say, for example, if blood sugar would have been advised or done in this patient earlier, and if GDM was diagnosed, then this case would have been managed in a better way, and IUFD could have been prevented. Because in this type of cases, when something goes wrong, usually in court of law, very important questions come that was it preventable? And in this case, you cannot say no. Of course, it was preventable. So if it was preventable, then what did you do to prevent it? One more questions come. And one more question, in spite of all your care and caution, if you couldn't prevent, then question will be there, why you couldn't prevent it? And if you couldn't prevent it, then that very complication, did you diagnose well in time? And one very important question, did you manage that situation way in which any prudent gynecologist would have managed? So if you can answer all those questions, then you could be out of problem. But for that, all necessary investigation, that is antenatal profile, we have to advise well in time. Actually, on very first visit, we have to advise, and regularly when it is required, we have to advise all necessary investigation. Yes, next.
So next we have Dr. Sushma Tarak with us, sir. She is the
Welcome.
secretary of Yawatmal Society. So over to you, Sushma ma'am.
Okay, ma'am. Good evening, all respected faculties, my teachers, Dr. Poonam, respected Poonam ma'am and Chhabra ma'am. Listening Poonam ma'am is always a feast. I always remember my postgraduate days when I listen Poonam ma'am. I am very privileged to be here with you all stalwarts, and I am thankful to MC Patel sir and Asha Jain ma'am for inviting or involve me for this webinar. Sir, my question is, what is the importance of records?
Naturally, record is always at your rescue whenever you are facing litigation, because it is a mirror of your treatment plan which you offer to the patient and how you manage that very patient. So proper record is always at your rescue. So you have to keep all this record up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by ethics and law. So how we have managed that very patient in that very given situation is only be proved by our record. Say, for example, nicely mentioned, discussed by Dr. Poonam Madam as far as management of eclampsia is concerned. If it is a case of eclampsia, you have managed that very case very efficiently. But if you have not mentioned well in that very indoor case paper or in your record, then it is as good as you didn't offer that very treatment. Say, for example, in case of this convulsion, etc., if you have given Maxel, and if you have not mentioned in record, it is as good as Maxel was not given. So records are always at your risk, and naturally good record is good defense, poor record is poor defense, and no record is no defense. And it is experienced during my medical legal practice. We gynecologist friends are very poor as far as record keeping is concerned. And many a time it becomes difficult for me also to defend our Foxian friends when they are having very poor record. So naturally records are always at your rescue, and it is very important document. I would like to mention one more important thing, that as far as record is concerned, whichever treatment you gave to the patient, you will mention, but purchase of emergency drugs and purchase of some instrument like oxygen cylinder, ambu bag, ventilator, this is also part of your record. And not only purchase of oxygen cylinder, but refilling of oxygen cylinder, bill of refilling of oxygen cylinder is also part of your record. Because in one of the cases which happened in state of Gujarat only and decided in National Commission Delhi, allegation on part of relative was when patient suffered heart attack, oxygen cylinder were empty in the hospital. And we were saved in that very case only due to bill of refilling of oxygen cylinder just one day prior. So this is also a very important part of your record. So naturally, we should be updated with all our records of treatment given to that very patient in that very given situation. Yes, next.
What is the importance of discharge card?
Yes. This importance of discharge card is equally important because it is again mirror of your treatment given. So at the time of discharging patient, naturally you will issue discharge card with all the details, personal information of patient naturally, your provisional diagnosis, if possible, final diagnosis, all the investigation you advise and did it, and all the treatment. And very important part is instruction. Instruction to be given to the patient at the time of discharge should be mentioned in discharge card. Say, for example, diet and medicine to be taken, exercise, follow-up, and references. As far as follow-up is concerned, if you have mentioned that follow-up after 1 week, and if patient doesn't turn up, it becomes a contributory negligence on part of patient, and it becomes good defense in your favor. So whatever you have mentioned in discharge card will be at your rescue. One more thing, reference. If at all you have referred that very patient to any other specialist for any other reason, you have to mention in discharge card, please consult Dr. So-and-so for this complaint. And I would like to mention one very famous case which happened in state of Tamil Nadu. It was premature delivery. Baby was admitted in NICU, and in due course, baby was discharged from NICU. But during course of admission and at the time of discharge, nobody advised, that is neonatologist didn't advise parents to have an opinion from ophthalmologist to rule out retinopathy due to prematurity. And ultimately in due course, baby went blind, case was filed, and case was decided against hospital and doctor. So compensation of 1.8 crore was awarded to the patient party. Of course, it was happened in government hospital of Tamil Nadu. So 1.73 crore was to be paid by government of Tamil Nadu, and rest of the amount was to be paid by neonatologists. Luckily, in this case, gynecologists were not made party. So whenever you have to advise some very important advice or some important instruction, it should be mentioned in discharge card. It should be discussed with patient, of course, but it should be mentioned in discharge card also. And copy of that very discharge card should be with you, because once you hand it over to the patient and something goes wrong, and if litigations happens, smart advocate on part of prosecution may misplace this discharge card. They may not produce that discharge card in court of law. So you should have a copy of that discharge card also with you. So at the time of whatever instruction given, whatever medicine advice, everything should be in your indoor case paper also at the time of discharge.
Okay,
Yes,
sir.
next. Yes, welcome. Yes, madam.
So next we have Dr. Sheila Shelke. She's a Jepaigo Master Trainer for Nurses, Lakshya Manyata Lead Assessor at Wardha, has many awards, many publications. So welcome, ma'am. She is also the president of Sewagram Wardha. Sheila, ma'am. I can see her.
Hello. Good
Yes,
evening,
ma'am.
ma'am.
Yes,
Thank you
madam.
so much. Presently, ma'am, President is Poonam Verma Shivkumar, ma'am. 2024. Ma'am is President. I am obliged to work in MJMS Sewagram. Whatever I am now, I owe it completely to Poonam Verma Shivkumar, ma'am, and Chhabra, ma'am. I'm thankful to MC Patel sir for including me in this session. I'm thankful to everyone. I'm thankful to Asha Jain ma'am for her so prompt response and follow up with each and everyone, including small society members. I would like to ask sir question: which are the areas for litigation? Which are the assisted obstetric situation which may lead to litigation?
So as far as
Over
area
to
of
you, sir.
litigation is concerned, usually during pregnancy, during labor, after labor, or in a operative condition after surgery, very common allegations are delayed in diagnosis, delayed in advising investigation and treatment, wrong diagnosis, no consent taken, staff not qualified, infrastructure issues, unnecessary investigation. Nowadays, this is also one more allegation. Because to be on safer side and medico-legally not to end up into, we advise certain investigation and many times cost goes higher. So this is also one more allegation, unnecessary investigation. Emergency services not rendered properly. Complication related to our treatment or that very condition, and communication failure. And as far as complication part is concerned, and ultimately morbidity on part of the maternal and fetal, and in very rare condition, mortality maternal and fetal. And one more area is failure of procedure or failure of operation. Say, for example, if we have advised forceps delivery and if we fail, then it could also be one more litigation. Trauma, injury, hemorrhage, infection, complications of anesthesia. These are some areas as far as litigation part is concerned. And one more allegation is coming up in today's scenario, overcharging or exorbitant charges against unexpected result. This is also one more allegation. And one more allegation, ask for record and hospital or doctor didn't produce those records. Because if a patient or patient party ask for any record, then we have to give those record within 72 hours as per guideline from Medical Council of India and with guideline of NMC, newer version of Medical Council. Within 5 working days, we have to give all those record to the patient. So if we have not given record to the patient, then also it is one more area. One more area, improper diagnosis of fetal distress leading to delayed delivery and ultimately some mishap happens or some morbidity happens. Improper monitoring of process of labor leading to complicated labor. Or many a time improper interpretation of CTG, delayed in taking judgment for instrumental delivery or cesarean section. So these are some area as far as litigation is concerned. But we are in a very tricky situation because on one hand, media and government are shouting that there are increasing in cesarean section rate. And on other end, in so many of the cases, allegation is cesarean section was not done in time or was not done at all, and that is why this situation happened. So we are under this problem in this situation. And as far as some assisted conditions or procedures are concerned during our treatment in labor, external cephalic version, internal podalic version, I mentioned prior also vacuum delivery, forceps delivery. So these are the areas as far as litigations are concerned. And one more area, birth injury. So birth injury to mother and to baby. Say for example, obstetric anal sphincter injury or perineal lacerations, perineal hematoma, paraurethral injury, VVF, RVF, cervical injury, rupture of uterus. So these are all these conditions in which we may end up into litigation. Yes, next.
Sir, I would like to ask
Yes.
one more question, sir,
Yes,
if you
yes.
don't mind.
Welcome, welcome.
Sir, nowadays there is a tendency of post MS people are who are in practice in Mumbai and some other areas. They are doing law in criminal negligence. Does it has any benefit for us?
I couldn't follow. What
Sir,
did you
I
say?
would like to, sir, the practitioners in Mumbai and some areas of north side, they are doing nowadays law in criminal negligence.
Acha, law. They study law.
They
Sir,
study law. After doing
yes.
MS, they are practicing and they are doing law. Does it has
Whatever-
any benefit or implications in practice?
Whatever you study, it will be beneficial too. When I did my law long back, 30 years back, LLB and LLM in criminology, I never thought I will be in practice of this CPA and PNDT cases, etc. But it was need of time, and though I was good in my obstetric and gynec practice, I was very busy obstetrician. But I switch over to this practice due to need of time. So if you have learned law, then it will be naturally beneficial to you. But even if you have not learned, then you have to simply have my mobile number. At any given time, you can have a phone
Sure,
call
sir.
to me.
I have that thing. Thank you so much for telling
Yes.
us.
So
Thank you.
I am ready there as far as any legal
Yeah.
consequences are concerned.
Yeah.
Yes.
So next we have Dr. Rajshri Narod Dasarwar ma'am. She's a consultant obstetrician and gynecologist at Mangal Murthy Hospital, Nanded. So welcome, ma'am. Dr. Rajshri ma'am.
Is she there?
No, she's not there. I would request somebody, would you please take this?
Anybody can take. Anybody can take.
Sir, hello.
Yes,
Can I
yes.
read it for Rajeshri, sir?
Oh, yes. Oh, yes.
What is negligence? What are the types of negligence? Against whom complaint can be lodged and where complaint can be lodged?
So as far as negligence is concerned, in our curriculum of MBBS in forensic medicine, we were taught two words, act of omission and act of commission. So what is act of omission? Act of omission means not to do something which any prudent doctor would do. Say, for example, giving full dose of penicillin without negative test dose. Because in that very situation, any prudent doctor would go with negative test dose, and then only he will go with full dose of penicillin. And if we give full dose of penicillin without negative test dose, then it becomes a case of omission, act of omission. Act of commission, with doing something which prudent doctor would not do in that very given situation. Say, for example, if you have planned surgery, and if you have planned that very surgery in general anesthesia, and patient has come up with full stomach, and if you give general anesthesia on full stomach, and if something goes wrong, it becomes an act of commission. Because in planned surgery, no prudent doctor would go with general anesthesia with full stomach. So these are part of negligence. And to prove negligence against any doctor, there are 4 ingredients. And first one ingredient is legal duty. So as soon as any patient comes to you, and if you accept her to treat, your legal duty starts from that point of time, because it becomes a contract or implied contract between patient and yourself. You are offering your expert services, patient pays for that, or patient promises to pay for that. So it becomes a contract. So this is your legal duty. Breach of legal duty of due to carelessness during treatment, or negligence, not taking proper care during treatment. So it is a breach of legal duty. And third ingredient is damage suffered by patient. So if at all patient suffers any damage due to breach of your legal duty, and very important reason or fourth ingredient for negligence is action of doctor should be direct and proximate cause of such damage occur to the patient. So doctor's action should be the direct reason or proximate reason for damage suffered by the patient. So if the 4 ingredients are proved, then it is proved that doctor was negligent. As far as type of negligence is concerned, civil negligence and criminal negligence. As far as civil negligence is concerned, usually cases are tried under civil suit in civil court or under CPA as far as compensation party is concerned. But if patient and patient party are interested to lodge criminal complaint, then they can lodge criminal complaint also. One more question you have asked, against whom complaint can be lodged. As such, if I go in a very one line, any service provider against whom complaint can be lodged. And where complaint can be lodged, it depends upon the patient and patient party's desire. If they are only interested in compensation, then they will go in civil or CPA. If they are interested to lodge criminal complaint, then in police station or criminal court. But they may prefer complaint against doctor in medical council also, if they are interested to have disciplinary action against doctor. If doctor is working in government hospital, then they may complain in government or in that very hospital department also for departmental inquiry and proper action. Human Rights Commission or any other commission, one can also lodge a complaint. And many a time now, patients and advocate on part of patients are very smart to harass doctor. They will lodge complaint at a time in all these fora, in CPA, in criminal case, in medical council, in government, in Human Rights Commission, etc. So this is now new scenario as far as litigation part is concerned. Hope I have justified the questions.
Next, we have Dr. Gargi Bahekar. She's a PG from KM Hospital, worked as assistant professor at GMC Gondia, consultant at Bahekar Hospital. She's author of Diabetes in Pregnancy, Venous Thromboembolism in Pregnancy in High-Risk Pregnancy book by Fernando Arias. So that is quite something. And she is a Bharatnatyam dancer. She's won various state level competitions, enjoys trekking, badminton, and reading. She's one of the 2 people who actually shared their photos with me. So thank you so much, Gargi ma'am. Over to you.
Thank you so much, Asha ma'am, for such a lovely introduction. I'm very thankful to Dr. MC Patel sir, Dr. Asha Jain ma'am for involving me in this wonderful webinar. And it's been a pleasure listening to all the seniors and listening to sir. So my question is, what is the importance of consent and what is the type of consent that should be taken in a case of normal labor?
So naturally consent is very important, because without consent, you cannot even touch the patient. So consent is very much important. But as far as common examination is concerned, it is implied consent, because once you take history and you say patient to go to examination table for examination, and if patient goes to examination table and sleeps on table, then it is presumed that it was implied consent. But if you have to intervene for anything that is invasive, you have to go with consent naturally. And without consent, it becomes very difficult, if at all, if you are facing any litigation. As far as normal labor is concerned, it is not prevailing in India, but it is very much required to take consent for normal labor also, because we never know. She may end up into complete perineal tear or any other complication, and we have to deal with situation accordingly. So consent for normal labor is also equally important. And as far as this normal labor part is concerned, consent should be taken when patient is with sound mind, because many a time there could be allegation that when consent was taken, patient was in agony of labor pain, so consent taken is not valid consent. So in this situation, if it is book patient, then we can give consent paper to the patient. They can have study at home, and in next visit they can sign the document. In an emergency, on admission only, you can have consent for normal labor. But you have not to remember all this. You have to simply visit Foxy website. And Foxy website, under title of Foxy Uniform Consent, we have prepared 30 different consent. Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consent. And in those consent, consent for normal labor is also there. So you can download that consent and you can use in your day-to-day practice. It is available in English, it is available in Marathi also, and it is available in Kannada also. So whoever is interested to have a version of that consent in Marathi also, they may contact me. I will forward it to person. As far as case decided, as far as consent is concerned. So it was a very famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And in that very case, Supreme Court came up with guidelines that what should be the ideal consent in Indian context. And Supreme Court gave some ingredients as far as consent is concerned, some criteria. So which are the criteria for any consent to be valid in eye of law and in Indian context was decided in that very case. So we have no time to discuss all these ingredients or criteria because it needs a separate lecture also. So I think it's enough as far as these questions are concerned.
Thank you, sir. So one more question I wanted to ask is, whenever we have a high-risk patient, say for example, a severe preeclampsia, or a patient who has who has had PPH and who is in the ICU, and we are monitoring and counseling the patient and the patient's relatives regarding, say, need for blood and blood products, or subsequently, if required, she may need to undergo, say, an obstetric hysterectomy if the bleeding is not controlled. In this case, we always take the patient's or the relative's sign, not the patient, maybe the relative sign in the language that they understand. How important is it to do a video recording of this counseling?
Yes. So if you have taken this type of consent or paper, it is also enough. But if you have video recording, then I would like to mention that video recording is of course good, but it is double-edged sword. Because if you miss any important points at the time of taking video consent or video conferencing, then smart advocate on part of patient may initiate that very point that you didn't discuss that, you didn't discuss that. So even if you are going to go for video counseling or video consent, copy of that consent in high-risk pregnancy cases should be with you on table, and no important point should be missed at the time of counseling and taking video conferencing and consent.
Thank you so much.
So it is also available on Foxy website, how to counsel patient or patient party and take consent in high-risk cases.
Thank you, sir.
Yes.
So we have only 15 minutes and we have 5 cases to be discussed.
Okay. Very quickly, yes.
So Dr. Kishore Ratnurkar had a family emergency, so he's not able to join. Dr. Gargi, do you mind taking this case?
Yes, ma'am.
Yes, ma'am. Welcome.
Please take this case.
Yeah, Gargi, madam, you are muted. Please unmute.
Ma'am, you have to read the case.
But she is muted, so please unmute.
Ma'am, I don't have the case with me.
Yes, it is on screen.
It's displayed on the screen. It is on the screen.
Okay, yes, I saw it. It's a Gravida 2 Para 1 Living 1, averagely built with previous LSCS, had a planned C-section. Intraoperative period was uneventful. No past significant medical history. Patient was planned for discharge on 4th post-operative day. On 3rd post-operative day, patient was taken for dressing. Suddenly, patient collapses, became cyanosed. CPR was started but could not be revived back. The cause of death, pulmonary embolism. How to deal with this situation when the attendants have started creating nuisance?
If attendant have started creating nuisance, first you have to inform police. And if you have rush team in your society, you have to inform 1 or 2 members of rush team. So they will be at your rescue in this type of situation. And once police comes, you have to advise or you have to offer post-mortem examination to prove our diagnosis when it is a case of pulmonary embolism. So these are the two things we have to do. As far as pulmonary embolism happen and patient has sudden collapse, we have to try to resuscitate that very patient, and we have to document all this, what we did to revive that very patient and how we manage that very patient in that very given situation. If you have involved your professional colleague in this situation as far as resuscitation and further treatment is concerned, then you have to mention in your case paper that also, that it was seen by Dr. So and so, and whichever the findings of that very doctor is to be mentioned, and whatever advice, whatever treatment he has advised is to be also mentioned. It shows your consent, because in court of law, ultimate result is not taken into consideration always, but your efforts to save life of patient are very much important, and you have to prove in the court of law that you have taken utmost care of that very patient in that given situation to save life of patient. Yes, next.
Next, we have, can't see the name, Dr. Sayali Jagirdar ma'am.
Sayali Jagirdar.
Sayali ma'am was here. I could see ma'am.
Yes, she is there.
I'm there, ma'am.
Yes, yes. Welcome, Dr. Sayali.
But she
ma'am is the clinical secretary of, ma'am is from Amravati Society.
It's okay, ma'am. It's no problem. Very good evening to all of you. And I'm really thankful, MC Patel sir and Asha Jain ma'am, for including me in this webinar. And it's always a pleasure to hear MC Patel sir to you. How many ever times I've heard you, it's always been very, very nice.
Yes.
So recently, we had MC Patel sir in Amravati for a very good panel and also a very good talk. So I would like to ask you this situation. A patient with labor pains was admitted with labor pains in good health at the time of admission. There was no satisfactory progress, so cesarean section was advised. Patients and relatives were reluctant to give consent as usual. The doctor was constrained due to non-cooperation from patient side, but he warned the attendants, including the patient, either to give consent for section or to take the patient to any other hospital. But the relatives did not take the patient. After 1 hour, the attendants gave consent for section, but asked for guarantee of mother and baby. So in these situations, when the relatives are initially very not cooperative with the doctor, but later on they ask guarantee of mother and baby, what are we supposed to do?
So at the time of when you have advised cesarean section, you have to mention everything in your case paper. What is the condition of patient? Why you have advised cesarean section? That is indication. And if patient and patient party not ready to give consent, then you have to mention that also, and you have to take signature in negative consent. It is very important part, because when patient doesn't follow your instruction, it becomes contributory negligence on part of patient. So you have to mention everything in case paper. If patient and patient party not ready to give negative consent also, in few of the condition, it is also the condition. So you can have a signature of any co-patient or any third party, any visitor of hospital, that it was explained before us to the patient and patient party and they were not ready to give consent. You have to mention everything. After 1 hour, when they give consent, but within that the 1 hour, what happened, you have to mention in your case paper. Because if it is acute emergency, when you have advised cesarean section, and after 1 hour when they are ready to give consent, then naturally condition may be deteriorated. So you have to mention at that point of time what is the condition of patient and what could be the probable prognosis. It is to be explained that you have delayed in giving me a consent for 1 hour, and now situation is this. And when they ask for guarantee, you cannot give guarantee. You can give guarantee of your best efforts only. So you can say like this, I will do my level best, but you have delayed in giving me consent for 1 hour, and this condition has happened, or condition is deteriorated. So you have to explain everything before you proceed for cesarean section. Because if you, without explaining this, without taking a signature or so, if you proceed and something went wrong or some morbidity happens, then it will be difficult for us to face the situation. So before we proceed with cesarean section, very quickly, we have to explain everything.
So in this very patient, the LSCS was performed, but the baby which was delivered was asphyxiated with a very low AGWA score. The baby was having convulsions also. Baby was intubated, shifted to NICU. The attendants now started blaming the doctor, saying that he gave false hope of normal delivery, gave wrong medicines, did not check fetal heart during labor, administered some injection which stopped the pain for some time, and then compelled the relatives to give consent for section. The baby was saved but developed cerebral palsy, and now the relatives filed a case against the doctor. So, how to deal with these situations? Where initially, most of the time, the relatives are responsible for the condition of the baby.
Yes. So I mentioned during discussion prior that we have to take consent of patient. Patient were not ready to give consent at that point of time when cesarean section was advised. After 1 hour, they gave consent. So whichever condition deteriorated in that very 1 hour, we have to mention at the time of this. And when baby is delivered with low ABGAR score, if we have explained everything before cesarean section, when it is delayed in giving consent, that it could be the probable prognosis, baby may come asphyxiated or compromised. We have to shift baby into NICU, and even then, no guarantee can be given. So if we have explained prior, then it becomes little easier one to face this type of situation when something goes wrong. When in this type of situation, baby is shifted to NICU, and naturally when baby is shifted to NICU, expense etc. also will be there on shoulder of patient and patient party. So they will be aggrieved in this situation. But once cerebral palsy happens, then again we will have to prove in court of law that if consent would have been given well in time, and if baby would have been delivered well in time, then it could have been prevented. So we have to explain everything in this situation.
So the last part, Dr. Sayali?
Yes, sir.
The last part, how to handle the
handle. So if at all the relatives allege about negligence, then how can we prove in the court of law?
Yes. So I mentioned prior also in one discussion that usually in this situation, first question will be there, was it preventable? And we have to say, yes, it was preventable. If consent would have given well in time, then this asphyxia or compromised condition of baby would have been prevented. So we have to mention that also. And one more thing, with our documentation, we can prove in court of law that we had advised well in time, but patient and patient party were not cooperative that way. So you are saved in this type of situation.
Thank you so much, Sayali ma'am. I might call you again.
Okay, no problem.
Ma'am is from Amravati. It was so small written, I couldn't read it.
Sorry, so no, it's okay, ma'am. No problem.
Dr. Monica, would you take this?
Yes, ma'am, definitely. Sorry, I'm not putting on my camera because I'm in the labor room. So the next question is 32 years old primary, full term, was admitted with labor pains. However, there's no past significant medical history. An artificial rupture of membrane was done and the liquor was clear. This patient had a sudden cardiac arrest while in labor and was pulseless, and BP was not recordable. CPR was performed immediately and amniotic fluid embolism was suspected. This patient was intubated and started with positive pressure respiration immediately. Patient showed signs of partial revival. What should be done? Should an LSCS be done immediately as fetal heart was present, or the patient should be shifted to ICU or a higher center? And if the patient immediately expires, then how to handle the situation? Thereafter, if the patient was shifted in ambulance to the nearest tertiary center with positive pressure respiration. Yes, ma'am.
Let's sir answer the first three questions.
Yes,
so
ma'am.
what should be done? Should cesarean section be immediately as fetal heart was present? So in this situation, when it is a case of amniotic fluid embolism, naturally we have to resuscitate that very patient. And peripartum cesarean section is one condition. If fetal heart is there, it will not help only to survive fetus. But in case of resuscitations in this type of situation, once we deliver patient within 3 to 5 minutes, then it could be beneficial as far as resuscitatory part is concerned. And as far as shifting to ICU or higher center, once we have resuscitated, once heart is back, then naturally we have to shift patient to higher this ICU or in HDU to take utmost care of that very patient. But if we do not do anything and straightway we refer patient to ICU and on the way patient expired, then it becomes difficult for us also to face the situation. So we have to try for resuscitation. We have to go for cesarean section emergency, that is peripartum, and deliver baby and continue resuscitation at the time of cesarean section. But it should be very quick. Within 3 to 5 minutes, baby should be out. And I would like to mention one case which happened with our own Foxian friend in Riva Medical College, head of the department, Dr. Binu Kushwaha. She had the same situation case and she went with peripartum cesarean section, and luckily baby and mother both were saved. Of course, it is not guarantee that if you go with peripartum cesarean section and then mother will be saved in all the conditions. But it shows your concern that you have taken utmost care in that very given situation. Now, one question will come that for that, as far as consent is concerned, in this situation, no consent is required because whatever you are doing to save life of patient. So no consent is required in this situation. If patient immediately expires, then how to handle this situation? In spite of all our efforts to resuscitate patient, if patient is not revived and we have to declare bad news, then naturally we have to have a phone call to member of rush team if you have rush team in your society. So 2, 3, 4 friends will be with us at the time of declaring bad news. If you have apprehension that relative may go hostile, then you can inform police also in prior, because ultimately you have to advise postmortem examination also to confirm the diagnosis. So to inform rush team, to inform police will be the answer in this situation.
Please take it forward, Dr. Megha.
Thereafter, the patient was shifted in ambulance to the nearest tertiary care center with positive pressure respiration. In the ambulance, the doctor accompanied the patient, but unfortunately, the patient expired. Attendants brought back the dead body and started creating nuisance in the hospital. How will we handle this situation and whom to call for help, sir?
Naturally, I mentioned police and a member of rush team. But in this situation, when doctor escorted that very patient in the same ambulance with all emergency drug, oxygen cylinder, IV line on, it shows consent of doctor to treat that very patient in that very given situation. And the same type of case, it was real happened with one of our Foxian friend in Ghaziabad. It was case of amniotic fluid embolism, and she resuscitated patient. Patient was shifted in the nearby center. In the same ambulance, she escorted the patient, and in due course of treatment, ultimately patient expired. Case was filed against our Foxian friend. She lost that case in lower court, but in Supreme Court, appeal was filed, and in Supreme Court, case was decided in favor of doctor, because in that very argument at the time of facing in Supreme Court, we could produce references from standard textbook of Williams. What is amniotic fluid embolism and how it is diagnosed and what one can do in that very given situation. So as per guideline given in Williams textbook, our gynecologist friend had treated that very patient, and we could prove in court of law that we had treated that very patient as per guideline from Williams. We went with 2 cases which were decided in Supreme Court in past. And in one of the cases, it was case of amniotic fluid embolism only. And in that very case was decided in favor of doctor. So with two cases and Williams standard textbook references, in this case also case was decided in favor of our Foxian friend. And at the time of deciding this case, Supreme Court has very specifically have a remark that if at all there is emergency, doctor has to take decision to take utmost care of patient to save life of patient. And it is not at all compulsory that result should be in favor. Result could be against. But if doctor has treated that very patient way in which any prudent doctor would have treated, and as per standard medical norms, then it is difficult for court also to declare negligence on part of doctor. It was the inference held by the Supreme Court at the time of deciding that very case. So if we have treated that very patient well in time as per standard norms, and if we can prove all this in court of law with good documentation, and if we present our case well in before a court, then it is all likely that court is always kind enough to consider our efforts.
Sir, we have 5 more minutes and only 2 questions left still.
Yes.
So, sir, one thing is, will a postmortem be helpful?
Yes. I mentioned, if we go with postmortem examination, our diagnosis is confirmed. So it will be easier for us to also prove in court of law that it was case of amniotic fluid embolism. Our previous case we discussed about pulmonary embolism.
So next we have Dr. Lalita Lokhande ma'am from Amravati. Welcome, ma'am. Lalita ma'am. Dr. Lalita Lokhande ma'am.
Is she there or anybody can take?
Ma'am is there, sir.
Yes. Yes, madam. Lalita madam, welcome.
Welcome, Dr. Lalita.
Hello.
Yes, welcome, madam.
I think she is not able to unmute herself, sir.
No, we can hear her. She keeps saying hello.
We heard hello. Yes, Lalita madam.
She messaged that she was not able to unmute.
On screen,
there is something wrong with her audio. Dr. Sayali, you mind taking this also?
Yes, I'll tell this patient. Baby Ramya, it was a situation number 4. Baby Ramya versus Dr. Aruna Reddy. Now the facts of the case were, there was a forceps delivery. Baby of 4.5 kg was delivered vaginally and the baby developed brachial palsy. The case was filed. The defense on the part of the doctor was that it was a complicated case. Patient was told to undergo elective section, but the patient had refused. And then after delivery, there was shoulder dystocia at the time of delivery. The baby was slightly asphyxiated and developed brachial palsy. Now the inference held by court was, the patient was admitted at 6 a.m. in the morning and the delivery started at 4 p.m. in the evening. There was no investigations, no sonography, no evidence that the consent was refused. And so the court gave compensation to the patient of 1.75 lakhs. So what do you think, where the things must have gone wrong?
Here again comes a role of proper counseling and consent, because baby was 4.5 kg. If it was diagnosed by sonography or so, and if patient was insisting to get delivered vaginally only, then at the time of counseling, one should explain that 4.5 kg baby delivering vaginally, it could have some problem. So we have to explain that also. And if cesarean section was advised in that very condition, and if patient refused, then it is to be documented, just we discussed prior also, so do not want to go into detail. And as far as this investigation or sonography part is concerned, if you have managed that very patient or attended that very patient very regularly from 6 a.m. to till delivery, very regularly by your findings, by your treatment part, etc., then if at all it is required for any investigation, then only you can advise. it is not necessary that you have to go for investigation. Of course, it is, if at all it is required, then you have to advise. But if you have attended that very patient and if you are documented well, you can save yourself in court of law in this type of situation. Yes, next.
So next is Dr. Samta Chaudhary. She is the recipient of Surakshit Matritva Din felicitation for good work. She loves to dance and receives many prizes. So welcome, Dr. Samta. She is also from Amravati. Dr. Samta, we can't hear you. You have two instruments on. You need to be speaking from the other one. We can't hear you at all.
She is visible but not audible.
Yes, sir. Can't hear her. Requesting somebody who's present here, would you please read out the question? Sir, I think I will read it out for you. Dr. Gargi, you want to do it? No.
So, ma'am. So, this is a case, Neena Gupta versus Deep Nursing Home, CPC 116 Chandigarh. The facts of the case were that it was a forceps delivery. The lady developed a uterovesical fistula. And the defense on the part of the doctor was that it occurred during the process of assisted delivery. The court held the doctor liable. So where did the things go wrong?
So at the time of forceps delivery, naturally we have to go for consent again. And of course, it is very rare possibility as far as this uterovesical fistula is concerned. But if it is a prolonged labor, due to constant pressure of head to that very part, many times necrosis develop, and after 1 day or so, that necrotic part sloughs out and RVF or VVF happens. So if we have explained that, then it could be easier for us to face in court of law. And usually in this type of situation, they have allegation that it was trauma or injury due to forceps. But many times it could not be with due to forceps also. This could be due to this region of prolonged labor also. So if we have explained, if we have taken consent, and if we have mentioned in our consent paper, then it would be easier for us to face the situation.
Thank you,
Yes.
sir. Requesting the panelists, if anybody has any question, they could ask. Or otherwise, it's 8:35 and we would have to call it a day. I request voting from your society for Food Drug Committee, voting from 16th to 25th, and voting for Sir for President Foxy, voting from 1st to 10th August. Please vote for us.
Voting for Rashmi also for Practical Obstetric Committee.
Same dates, for 16th to 25th of August.
So consider my seniority, sincerity, dedication, and easily availability to any Foxian friends in any given odd medical legal crisis. I am always there to assist. Please consider and please vote and support for me. Election would be just mentioned by Dr. Asha from 1st August 10 a.m. to 10 August 5 p.m.
So thank you so much, respected guest Chhabra ma'am, Pushpa Jhungare ma'am, our speakers Poonam ma'am and Rashmi, and our chairpersons, our respected panelists, all the audience, and our academic partners, Corona Remedies, and Piyush and Nilesh in particular. Thank you so much. See you again next week, same time, 6 o'clock with another topic. So Piyush, you want to say something before we really end the session? And Poonam ma'am, aap abhi tak hain, so if you want to say a few words.
Before Madam takes over, I would like
Ma'am,
to
there was
mention
one question for you in the chat box.
Yes, but before that, I would like to mention all the helps from Dr. Monica. She is helping us a lot as far as this kind of webinars are concerned. So my special deep sense of gratitude to Dr. Monica. Yes, Poonam madam.
Yes, Asha, you said, was there any question?
Ma'am, there was a question in the chat box, how to prepare that 50% magnesium sulfate. And
Yes.
another question was whether to use 75 or 150 of EcoSprint.
Okay. So the first answer to the first question is that you take 8 ml of the vial, so 4 vials, 8 ml, and you add 12 ml of distilled water, that makes it 20%. So that is what you have to do immediately when you are giving IV. Answer to second question is that the CLASP trial was there, which said 60 something, so we started using 75. The ASPRE trial now says very clearly that 150 is a good dose, which actually prevents a lot of preeclampsias also, and the complications of preeclampsias are prevented. So those are
Thank
two.
you, ma'am. Thank you so
Yes,
much.
and I would like to only add one thing. Now, madam, IV Mag is also available. It is prepared solution.
Yes,
100 ml bottle. So no need to prepare. It is prepared solution, and you can use in.
Yes, only issue is for cost because it is slightly expensive than these vials. So that is why, it is not being used every time.
Yes,
But certainly, as Dr. Pushpa said, that it is available.
Yes.
Piyush, you want to say something before we end the session? Thank
No,
you.
ma'am. Good night.
everyone.
Thank you.
Thank you.
Thank you, everybody. Thank you, sir and Asha, for the opportunity.
Thank you, ma'am. I'm
Thank
sorry
you.
I
Thank
had to
you all.
interrupt you. I'm sorry.
No, that's perfectly fine. We have to see the time as well. No worries.
Okay, fine.